going to talk about a very interesting issue of polyuria, which is a common complaint which is observed in terms of pediatric practice. Most chronic causes of polyuria we will of course be identifying is diabetes. So of course we have to be very cautious in terms of not missing diabetes. So anybody who complains of polyuria, get a urine sugar and a blood sugar done from the first perspective. What we'll be discussing more today would be in terms of chronic polyuria beyond diabetes. So Dr. Sayan, which are the two basic categories of conditions which can cause polyuria? What can cause polyuria in that sense?
So one is decreased ABP secretion from the central axis and one is the impaired effect.
Nothing else? This is what you said about DI.
DI. So apart from this, all the other causes like diabetes.
So what you need to understand is that polyuria, urine, what is the urine doing? Why is the urine volume there? What is the major role of urine?
So to excrete the solute, the minimum solute that is required to be excreted.
So you have to excrete the solute and that solute goes into the urine. So there are two components which will decide the volume. One would be the load of solute. So you will say, of course, it will depend, the volume will depend upon the total load, upon the concentration of the urine. So there are two factors. One, if your load is too much, which is overwhelming the concentration capacity, like diabetes, like osmotic diuresis, like mannitol, all those situations, you will definitely have a situation in which you'll be losing a lot of urine. Or if you cannot concentrate. If you cannot concentrate, of course, you will need more volume for the same amount of load. So either your solute load is more, or you have got a higher level in terms of concentration problem, which will happen in that regards. What is the basic difference between these two conditions? How will you differentiate between increased solute load versus a decreased concentration? Which test will tell you? Let's put it simply at that. So if you have a concentration defect, what will be low? So of course your urinary osmolarity will be low, and if you have a solute load, your urinary osmolarity will be more. So you will try to excrete everything, body is trying to do that, but still it is going above the capacity. So single most important investigation in a child who comes to you with polyuria is to look at the osmolar status as far as the urine is concerned. If you have a concentrated urine which is going in more, it means that some solute is coming in the body. If it's a dilute urine, either if it's dilute urine, it could be because of.
So more commonly diabetes insipidus, the thing we need to look for.
Anything else?
And in case of any concentration defect, maybe
no concentration defect, you know, DI. Anything else? If you drink a lot of water, you will pass a urine. So one is that if you're drinking a lot of water, so too much fluid intake or too much free water loss will also cause polyuria. So we said urinary osmolarity will differentiate between solute load being more versus a concentration defect. How would you differentiate, Dr. Manoj, about increased intake of free water versus loss of free water as a primary thing? Both of them will have polyuria and polydipsia. Yeah. Okay. So what will you expect? The plasma osmolarity will be low, normal. You won't have usually low. So body will ultimately, there are other mechanisms which will come into the picture and not ensure that this is low. Similarly, in DI, we have talked about as soon as your sodium goes up, you will have a thirst mechanism coming up. You will not develop hypernatremia. But if you talk about free water excess, acutely, of course, you will have hyponatremia. Chronically, it will be low or in a low normal range. DI, if you don't have a thirst mechanism intact, you're not drinking water, you will develop hypernatremia. Otherwise, it will be high normal. Which other test, Dr. Prateek will tell you, differentiate the two? A very simple blood test. And we just discussed in a case which is not going to be presented today, presented again with polyuria. And we said, okay, this level is not low, which makes it less likely to be a excess free water. Absolutely. So if uric acid is low, it means there is a hypervolemia. That would mean that it may be a free water excess. You're drinking a lot of water. But if uric acid is normal or high, it means you are a bit dehydrated. So even if clinically you are not dehydrated, it would mean that there is a subtle sign towards diabetes insipidus going on. So as I said, two simple tests, and this is, we'll discuss much more in detail, urinary osmolarity and uric acid can really help you out which way to go forward. Urinary osmolarity on the higher side, osmolar load. Urinary osmolarity on the lower side, too much free water, or a problem in concentration. Uric acid on the lower side in those who have a low urinary osmolarity, it would mean it's a fluid overload. It's mostly a psychogenic polydipsia. And of course, if the uric acid on the higher side goes more in favor of DI in that perspective. Now, of course, there is a overlap, and that's why we have got so many other tests like water deprivation test, co-peptin, other things which we'll discuss subsequently in that regards and perspective. So all of you can go and have a look at our website, learning.growsociety.in, which has got a lot of information with regards to courses in terms of a lot of free modules available. You can access to various pediatric endocrine courses which are available, validated tools and assessment tools also there. We've got specific courses for fellowship in pediatric endocrinology and diploma in pediatric endocrinology, which are validated. Along with that, we have got 3 sessions which we run every month. One is this one, which is the postgraduate lecture series. There is a grand round and there is also a postgraduate grand round. So this postgraduate grand round is a single case which we discuss in detail, and we go a bit about theory as well today, and we'll talk about polyuria in that perspective. The books are available which you can access, and our mobile application is accessed in that perspective. Now, before we talk about the case, just to set the background, we need to understand that the tonicity of the blood is very, very important because it regulates the flux of free water between the cells in that regards. And the major regulator of tonicity of the blood is sodium. So effectively, I would say for clinical perspective, sodium is equal to tonicity in most situations. And this tonicity is basically controlled by 2 factors, the thirst mechanism and the AVP. I've discussed this earlier also, that thirst is the major defense against hypernatremia, and AVP is the major defense, AVP decrease is the major defense against hyponatremia. So if you are having too much of sodium, the body will start having concentration in terms of urine, as well as the thirst mechanism will be there. So AVP will go up and you will have more thirst, which will defend in that perspective. On the other hand, if your tonicity is on the lower side, the body will stop drinking water and will try to excrete the free water. So AVP will go down in that perspective. So when we talk about the output, we need to understand that it depends upon 2 things. How much is the osmol the body has to remove and how much you can concentrate. That makes it much easier. So roughly I am saying is that typically you have 500 milliosmoles per meter square per day. Now in that perspective, if you talk about a typical situation where your urinary osmolarity is less, you are only having a urinary osmolarity of 100 milliosmoles per kg, you have a urine output of 5 liter per meter square per day. However, if you make it normal in that perspective, you make it 1000. So there is a 10-time increase you can go up in terms of osmolarity. Then it becomes only 500 ml per meter square per day. So it's all a game of how much your osmolar load is. Suppose you have too much amount of glucose, you will need more volume to take it off. If you have less concentration, you will need more amount to excrete. So basically in that perspective, what we need to understand is that polyuria is either because of an osmolar load or a urinary concentration defect. Now, rest all, it becomes much easier from that perspective to understand. Now, if we look in a graphical fashion, what we need to understand is that this is the standard load. So usually, unless you have hyperglycemia, you have mannitol, you have got urea, resolving phase of renal failure, you will have this much amount of osmoles which are produced in the body. Now, as your osmolality, as I said, peak is around 1000. At that time, you are going to have very little amount of urine. But as your osmolality goes down, the urine output will exponentially increase in that perspective. And then you will have significant polyuria, which is going to happen because you're not able to concentrate that. To compensate that, you will drink water. So anybody who has got good thirst intake will only present to you in even with severe DI as polyuria and polydipsia. Now, Dr. Vibha, which conditions will present to you with hypernatremia? DI, which will present to you with hypernatremia.
So DI, individual host mechanism is impaired, so that will present with hypernatremia.
So either you are not taking water, or your center in which the water intake is controlled is defective. That will cause that situation, which happens in the setting of a post-operative case, which happens in the setting of an ICU admission, which happens in the setting of an infant, which happens in the setting if you have a destruction by a lesion of both the AVP neurons as well as the thirst neurons in that regard. So there is an inverse correlation with regards to the urinary output and the urinary concentration. So just to summarize, which we discussed earlier, at 100 you will require 5 liter per meter square, at 1000 you require 500 ml. So this is a huge 10 times variation which may happen in that regards. Now, which part of the brain senses thirst mechanism and which acts as a thirst regulator? Simon.
So the osmoreceptors in the hypothalamus.
So basically, there is always a osmoreceptor which are circumventricularly located. So they are outside the blood-brain barrier. So you will perceive how much the osmolality is there from that perspective. Now, as the osmolality goes above 293, the body will start say, okay, there's some problem. I would need to drink water. Now, this osmolality will then act through the angiotensin 2. Now, we have discussed that angiotensin 2 increases blood pressure by increasing the aldosterone level, by having a direct effect on the vasoconstriction, by having an effect also at the level of this thirst mechanism. So it's trying everything to build your amount of water in the body. Now, this will cause increased thirst in that perspective. Now, what will shut down this thirst mechanism, Naveen? When will body say, okay, I don't want to drink anymore?
So whenever there's a decrease in osmolarity.
So now if your osmolarity becomes 283, you will then have a decrease in thirst?
No, sir. Actually, whenever you take water, there's the receptors in the oropharyngeal region which basically cause inhibition of the thirst.
So what you need to remember is that insulin is secreted when your sugar goes high. But if you wait for insulin secretion to go down when your sugar basically goes down, it becomes too late. Similarly, if you wait for your sugars to go up and insulin comes into the body, it will be too much of a fluctuation. So body says as soon as carbohydrate reaches the duodenum, there is an incretin which is produced, and before your blood sugar rises, you have an immediate response which happens on insulin. Same. If you say, okay, I am drinking water till the time my blood osmolality becomes normal, you will become hyponatremic. So you will have hypo, this all will go on. That is why as soon as you have drunk a water, you will have these receptors in the pharynx which will say, okay, this person has already started drinking, so let's stop drinking more, the thirst goes off. Now, there is an immediate response as discussed, and which factors favor that response?
So if you take more of ice or cold water, it
Yeah.
will take even more.
So if you have got more cold, this becomes early satiated. That is why if somebody gives you a history of polyuria, polydipsia, first question you need to ask is one, whether there is nocturia or not. If there is nocturia, it means it is significant. Second is whether they have a preference for a cold water, ice. That would basically mean that they are having a lot of thirst and that quenches it quicker. So this is a classical history you will get for somebody who has diabetes insipidus in that perspective, and this oropharyngeal receptor will do that. This will suppress all those things, and coldness and water will be there. Now, one factor which is there is that the threshold for thirst is 293. Now, Dr. Pratik, what do you think? How is this compared to the threshold for AVP? The threshold for AVP should be lower than this or higher than this? Should be above. So if your osmolality is 300, then your AVP should come up, or less than this?
So AVP release starts before there is thirst.
Absolutely. Why?
In preparation, I mean, before only it starts.
So this is a very simple analogy. Suppose you have got a tub, a bathtub, and you are trying to fill the bathtub. One, it is leaking from one side and you are trying to fill it with water. If you want to fill it, you will like to stop the leak first, or you will like to fill it up. So that is a simple mechanism. You're losing a lot of water in the urine. So first thing should be to shut the urine, and then you start filling via the thirst. So the threshold, osmotic threshold for thirst is 10 milliosmoles per kg higher as compared to AVP. So AVP will start secreting at 283. This is going to be secreted at 293. And this is an important mechanism. Otherwise, it will be a waste. You're drinking and it's going in the urine. That's a very, very basic phenomena. So as discussed, so water basically is freely filtered. Lot of water is reabsorbed, but major resorption, which is hormonally regulated, happens at the collecting duct, and this is done via the AVP, which acts on the V2 receptor, acting through the aquaporin channel. And aquaporin channels are just like water collectors. So they are like you are sending these containers to get the water out, and they'll come back to it in that perspective. So aquaporin will work in that regards. Now, what does plasma osmolality do to AVP? And this is what we already discussed with Dr. Pratik, is that as soon as at 280 osmolality, you have got zero AVP. As soon as it goes above 283, it starts rising. And then there is a steep rise in AVP, which happens over time. What is the point, Dr. Sayan, at which you have got the maximum AVP response?
The maximum generally comes at around 300.
295, 300. So that's why 300 is used as a criteria for when your water deprivation test should stop. This is the aim of water deprivation, but it's around 295 or something, you will have maximum response generally. If somebody doesn't have a response by 300, that is even more significant in that regard. So what you see is that AVP starts happening around 283. It's a highly sensitive. This is, as I have been saying multiple times, the most sensitively controlled, the most carefully controlled parameter in the body is sodium. It's not your blood sugar, it's not your calcium, it's not your temperature. They have got a huge range. This is less than 1% change. You'll start having a problem, and body will start changing and reacting to it. And the set point, of course, may vary. If somebody is pregnant, somebody is in the luteal phase, somebody is hypovolemic, you will have a shift to the left side. But that's besides the point. We're not going to discuss much on that perspective. So thirst, as we discussed, has 10 milliosmoles later. So first thing, you shut the leak, and then you start getting water inside. This is the typical pool phenomena which we discussed. Now, within this context, we need to now understand as to what all can cause polyuria. So, Dr. Vibha, what can cause polyuria in this perspective? We have seen all the thirst and the urine output. So, intake. So, if you have,
is more, there will be polyuria.
So that is
For this psychogenic polydipsia.
so compulsive water drinking or psychogenic polydipsia, that is the increased intake. Now, that entity is debatable. Some people say it is because of some particular reason. Some say it is behavioral. It may be drug induced. Which medical condition can cause psychogenic polydipsia or compulsive water drinking? So it is like your thirst center is hyperactive. So you need to have something in the thirst center which can cause. So which condition? Which medical condition? Naveen?
So it could be any lesion in hypothalamus, or it could be because of mania.
So lesion will usually cause what? They will cause decrease. Sarcoidosis is one condition which can cause increased thirst and psychogenic polydipsia in that regards. So one is increased thirst. Second,
The second is
osmoles. If your osmoles go up, that would be,
increased solute.
so that will basically be glucose, urea, mannitol, all those things. One very important osmole is, which we are missing here, is
Sodium.
sodium and calcium. So when you're giving somebody a lot of sodium, that also is an osmole that has to be excreted in the urine. So sodium and calcium. So hypercalciuria, giving too much sodium chloride, DKA, all those factors will carry because body has to take it off. So we talked about increased water intake and increased load of solutes. Third,
Any hypothalamic lesion involving this.
so AVP defect. So any problem because of AVP, that's central DI. We'll discuss what are the causes there. And of course, problems in the V2 receptor, that's nephrogenic DI, and I'll include all the tubulopathies and everything here as well in that perspective. So this is the broad cause classification of diabetes of polyuria. So polyuria, more load, osmolar blood sugar, very easy to identify, urea mannitol, very easy to identify, saline load, often we tend to miss. So if you're giving too much saline, this can also cause polyuria. Which condition is this most common? Post-neurosurgical. Because a lot of fluid is given and then people are confused that this is a polyuria which is because of sodium chloride or is it because of DI? Which test will differentiate the two? Yes, so hypernatremia plus minus may happen in both. If you're giving too much sodium, that is why you're having polyuria. But if your urinary sodium is high, it goes more in favor of a too much fluid as compared to DI in that regards. That becomes important. Now, water, if you have compulsive or sarcoidosis, is one variant in which you can have that picture. Concentration defect we discussed could be tubulopathies, RTA, Bartter syndrome, diuretic use. What is the major cause of polyuria in RTA, in distal RTA?
So basically because of hypokalemia, which can.
So it's actually a concentration defect. It's not because of the tubular damage. They're not having that much loss. One, you have hypercalciuria, so you will take it along with that. You have got hypokalemia, that will cause the impaired concentration. So it's not tubulopathy per se, which is causing that much polyuria. It is because of secondary mechanisms. Similarly, Bartter syndrome is probably the only significant tubulopathy of which will really cause a lot of polyuria. Because again, hypokalemia will happen and that will persist from that perspective. Now, whenever you have got too much load of sodium, which is, so all these things like Bartter syndrome or diuretic use will cause too much distal delivery of sodium, which is happening in the tubular region. Whenever you have a distal delivery in the tubular system, what will happen to the glomerular filtration? Tubules have got a lot of sodium, tubules have got a lot of fluid. What will they tell the glomeruli? I want more fluid.
They will try to decrease the delivery that is happening to the.
So they will try to decrease. What they will do then?
So they will decrease the ANG system.
They will cause the artery will constrict or dilate.
So,
The afferent arteriole.
so afferent will dilate.
Afferent is the coming one. So that will constrict. So less amount of fluid will come in that perspective. So there is a tubulo-glomerular feedback. Any condition in which you got too much amount of free water, which or too much amount of sodium which is being delivered here, the glomeruli becomes less. Why does thiazide diuretic cause renal dysfunction? That's why it's used in the treatment of nephrogenic DI. It causes more delivery of sodium there. It causes vasoconstriction there. So GFR goes down. So diuretics, basically what I'm trying to say is that if you're using diuretics, you will have some polyuria to begin with. Often you will see after some day, they will say, okay, now the polyuria has gone. This is the reason, because now the body has adjusted. It is saying, okay, I don't want that much loss. I will constrict the afferent glomerule. But that would mean there is a renal dysfunction which will happen. So long-standing diuretic will ultimately have some amount of renal dysfunction which is going to happen in that perspective. So it is unlikely for tubulopathies to cause polyuria for a sustained state unless you have hypokalemia. So hypokalemia is a major mechanism. And of course, central and nephrogenic DI, of course, we discussed is a cause there. Now, how do you differentiate? Osmolar will have a high urinary osmolarity, all else will have low urinary osmolarity. Second, sodium will be low normal in most situations, except for impaired AVP effect where they will be high normal. So these are the two basic mechanisms which you can distinguish. So let's go one by one. Osmotic diuresis is basically you give glucose, mannitol, urea, you've got more delivery of sodium, and essentially you will lose all those things. So you will have high urinary sodium and chloride. So urinary osmolarity will go up. You will have hypokalemia and you may have hypernatremia, which is transient in that regards. Compulsive water drinking, you're drinking a lot of water, essentially more water delivery. It's basically a simple mechanism. Too much in, too much out. There's nothing much to think of. Of course, at very high levels of water, what will happen to AVP? If you drink too much water, what will happen to AVP? Will decrease, because already the volume is too much and your sodium may go a bit low. So AVP will be shut down, which means that there is also a secondary AVP problem in that perspective. You get my point? So even in what you say, a compulsive water drinking, they also have a relative AVP deficiency, which is happening in that regards. Too much water will also mean that ANP may also be in a picture. So a lot of these confusions may be there in that perspective. Risk. Now, if you give them AVP, now they have got zero AVP in the body, you give them AVP, they will suddenly go into hyponatremia. So that is why do not unnecessarily somebody is coming with polyuria, give them AVP, they will develop hyponatremia. Because if they have this condition, they are drinking water compulsive, they are already drinking more, they have zero AVP, body is trying to prevent hyponatremia from happening. That is why AVP is zero. But if you give them desmopressin, they will have severe hyponatremia, which will happen in that regards. Now, tubulopathy, as I said, generally will not have a problem here. And calcium, if the levels are high, you will have hypercalcemia, which may cause the situation and damage which will happen. And hypercalcemia also causes the same picture, which is there. So anything like Bartter syndrome or Gentleman syndrome, you will have a similar picture, which happens in that regard. So tubulopathy may be one situation you would be looking at in that perspective. Now, hypokalemia. How does hypokalemia, Dr. Pratik, cause polyuria? So it's like a nephrogenic DI. So hypokalemia, once the levels are below 3. So mild hypokalemia, 3 to 3.5 will have no effect. Once it goes below 3, you will again have an issue in terms of sodium delivery, and you will have decreased sodium absorption, and that will culminate into more absorption happening at the level of the collecting duct, and that will basically result in loss of water. So it's more of a concentration capacity which is there in that regards. There is also an aquaporin issue as well. So hypokalemia basically causes a picture which is like a nephrogenic DI in that regard. So anybody whom you want to evaluate for polyuria for water deprivation test, 3 things which are very, very important to do are, Naveen?
We need to rule out normal renal function. We need to rule out, and we need to rule out renal acidosis and hypokalemia, calcium, blood sugar, and also we need to have thyroid function test and cortisol level in normal range.
Yeah, that will be more towards the other way around. But if you talk about polyuria, I would say main will be creatinine, calcium, and potassium. Then blood gas and sugar will come even before that, because RTA will be an important thing in that regard, which will happen in that perspective. So hypokalemia causes this. Hypercalcemia, how does it cause polyuria, Sayan?
So hypercalcemia again by its osmotic effect, and second will be again by the resistance to LPH.
So whenever you have calcium above 11, so as I said, potassium below 3, calcium above 11, it will start acting, and we discussed about the effect of calcium sensing receptor on the whole process of this resorption. So if a calcium sensing receptor is disrupted, your sodium loss becomes more. And that will cause a huge problem. Again, the sodium has to be reabsorbed at the distal tubule, because body will say we are losing so much sodium, behaving like a diuretic, essentially, if we talk about that. And this will cause a loss of medullary gradient, and subsequently you will be losing more water in that perspective. So hypercalcemia, hypokalemia, metabolic acidosis, these 3 are major causes you have to exclude first before you want to evaluate for polyuria in that perspective and in that regards. And this will cause more loss in that regards. And of course, there's an aquaporin defect which happens also in that perspective. Now, diabetes insipidus basically is an issue in which you have got a problem in either AVP production or action, which is central versus nephrogenic TI. If it's not there, you will have a lot of urine which will come in that. This will be the most severe form of polyuria which will happen in that perspective. Your sodium will be high normal. Hypernatremia is usually unusual because people are drinking a lot of water in that perspective. Urinary osmolarity is of course low. So we have now discussed the overall background as to what really is polyuria, why is it caused. We'll now invite Dr. Naveen.
And this 13-year-old boy who was born out of a 3rd-degree consanguineous marriage came with the complaints of polyuria, polydipsia, and failure to thrive. And this is present since 1 year of age. It is present for a year of duration of around 12 years, and he visited a few doctors in between, but none of them showed any improvement, and he was free of any acute emergency. He did not have any consideration regarding this problem, and now he came to us basically because of the fact that his friends and his other students of his age group were growing in taller and also gaining a lot of weight, and he was not gaining in weight as also not growing in height. That's the reason he actually came to us at a very late present.
So just hold on. So when you say polyuria, polydipsia, and failure to thrive from 1 year, I think that itself will give you a lot of diagnostic considerations. So what do you think are the possibilities even before you go ahead further?
So in this case, it is more likely to be a diabetes insipidus, because other causes of polyuria, which we described right now, have already been ruled out because of the fact that.
One by one. Can it be a solute load?
So solute load, it's very less likely because of the fact that in case if it is high glucose, it can't be running so long.
So that's out. Can it be, now we talk about, can it be free water excess?
So free water excess can be a possibility of primary psychogeny or compulsory.
1 year onset is too
early for that
perspective to come. Then can it be tubulopathy?
So tubulopathy will have other manifestations as well. So in case if it is a RTA, you will have some form of bony deformities and other manifestations.
Proximal RTA will cause bony deformities. So tubulopathy
could be still a possibility.
If we don't talk about 13-year-old now, 1-year-old, if somebody is coming to you, of course you will start thinking tubulopathy as a major differential. Yes, diabetes insipidus you will think of. Which DI are you thinking of? At 1 year old.
Complaints for the last 1 year?
No, since 12 years, since 1 year of age.
Since 1 year, autosomal dominant central DI.
Okay, that is the first possibility you will think of.
So since 1 year, the possibilities.
So being a boy child, in it is nephrogenic could be a very strong possibility.
Because nephrogenic DI is the most common. Because the central DI, when we talk about central DI, we won't go into too much detail here because it's more of polyuria, but just to highlight, when we talk about central DI, either if it is because of malformation, if you have a septo-optic dysplasia, if you have a hepatic defect, that will present very early. That is not there. Most other defects are a 2-hit model. You have a problem in neurophysin gene. So it's the folding issue. So the initial first hit will happen a bit early, but that is not sufficient to cause polyuria. The second hit will mean that cells will die over time. It will take a few years perhaps. So if you have a congenital form of DI in a non-syndromic child, start thinking directly of a possibility of a nephrogenic DI rather than a central DI, that too because of a B2 receptor defect. So this is a very, very significant history. 1-year-old boy with polyuria, polydipsia and failure to thrive, tubulopathies versus DI. These two will be the major ones. Now, when you say tubulopathy, Dr. Vibha, which tubulopathy will you think of?
So at 1 year, so it would be distal.
So it doesn't mean it has to be RTA, it can be something else also. It could be Bartter syndrome also. So I would be less towards RTA, I'll be more towards things like Bartter. A milder form of Bartter syndrome will be more likely. Yeah. Which thing will be very, very important? Suppose you had come to you at 1 year of age with polyuria and you have ruled out diabetes and everything. Which clinical examination finding will really give you a clue for polyuria?
Weight gaining.
Failure to thrive is there. Which will really help you classify the problems in the tubular issues. Suppose you have hypokalemia, let's give a clue. You've got hypokalemia with polyuria, which thing on examination will give you a clue?
So in case infants, there won't be intake of water, sir. There can be skin changes of hypernatremia, which may be seen.
You're still talking about DI. You're talking about there is a child who has polyuria with hypokalemia.
With hypokalemia.
So you will look at what on examination? Blood pressure.
Okay.
Why?
Sir, because there throughout the role of RAS excess as well as
is that those RAS, anything which causes hypokalemia will cause polyuria. So all
Process.
apparent mineral excess
Will have hypertension.
will also present you with polyuria, polydipsia. So you have to keep your minds open. So if he is 13 years, it can't be Little syndrome, it can't be AME, it can't be CH. All those things is out. But at 1 year of age, you have to consider that. So blood pressure will be a very, very important thing to look at, whether there are hypertension or not. And neck flop will be there also in examination. This will give you a clue of hypokalemia being present or not. So now if we just look at 1 year presentation with polyuria, polydipsia, failure to thrive, it could be tubulopathy, maybe RTA versus Bartter versus RAS excess, whatever you want to club on that. Second, of course, will be the DI, which is there in that perspective. Now, what will differentiate these two on history?
Differentiate, basically there will be, as already mentioned, significant history with regards to polyuria in the form of nocturia, preference to ice, and also night awakenings. These
1 year will not give all that.
So at 1 year of age.
Yeah.
So
acidotic breathing, rickets. So
Dehydration,
that's what you said, which are not there, that also becomes very important. Now, out of these, which one do you think can be still there at 13 years of age? Which possibilities are more likely?
So the milder form of the tubulopathies can still be a possibility. Then RAS excess, but
Unlikely.
and very
RAS
unlikely.
excess undiagnosed from 1 year of age will die because of hemorrhage.
Okay.
Even that AME who did not have any polyuria had got so many
Recurrent strokes.
which happened by this. So it's too late. So if you have a clear-cut 13 years this thing, that means this is one condition which body is able to correct by itself. And the condition which body can correct by itself is DI, nothing else. So you're drinking water, that's why you are fine. But because of drinking water, you have failed to thrive. Because you're drinking water, you're not taking anything else.
Yes.
So this becomes very clearly that this is more like a DI picture, going by that, but carry forward.
And with regards to the polyuria complaint, this was present since age 1, and it was gradually progressive, and he never had his urine in yellow color. It never concentrated. It was always colorless. And when he went to general practitioner, he asked to monitor the urine input on urine output and water intake, and it was found to be with an output of 5 liter per day, which is 10 ml per kg per hour, or with respect to body surface area, it was 5.5 liter per meter square per day, and the intake was also very high, which was around 4.5 liter. And it was associated with nocturia. He has to wake at least 2 or 3 times every night to go for urine, go for passing urine, and it was not associated with polyphagia. And he had a increased tendency towards drinking cold water, and the patient came almost like 15 days before, which was like very cold weather. Despite being winter, he used to have a high preference for drinking cold water.
So 3 points on this, which will tell you that this is DI.
So basically nocturia, increased preference to ice, and it was colorless.
So color and odor, so always becomes important. If you have colorless urine, odorless urine, it means there is nothing in there, it's pure water basically. So that is very, very important. And you already talked about cold preference, you already talked about the nocturia. So this clearly goes more in favor of a significant polyuria, which is a concentration defect. Because in all other conditions, it will be not this much of a concentration problem. There you will be losing something, some sodium, some calcium, something will be lost. So that will become important.
And it was associated with the failure rate, which was the basic reason why the patient visited the doctor. And there was no recent weight loss. He has been not growing since his younger age. And there was an history of head trauma, which happened at around 3 to 4 years age, because it was not significant except for the scar which was actually present over the left eyebrow. And it was not associated with either loss of consciousness or significant bleeding or seizures. There was no history of rash or any seborrhea, no history of neck flop or lower limb pain or episodes of any paralysis, no deformities, lower limb deformities or any difficulty in walking, no vomiting or headache or visual disturbances or seizures. There was no history of any chronic cough or any history of recurrent fever. No history of any change in body color in the form of any hyperpigmentation, or there was no history for craving of salt. No history of any recurrent abdominal pain or hematuria. There was no history of lethargy, weakness, recurrent infection.
So now, if you
and there was no history.
Definitely. About DI now, we're thinking of DI in that perspective. What will suggest that this is more likely to be nephrogenic as compared to a central DI?
Sir, basically, in case if you're thinking of a nephrogenic DI, we need to ask for the family history in case if there's any maternal uncle who has been affected. And next thing, we need to ask for any antenatal history of polyuria. And also, we need to ask the mother whether she was having any form of polyuria during pregnancy.
So these three are the clear-cut marker that if you have an X-linked issue, you will have any of these problems which will be there. So that becomes important.
And with regards to the past history, he had an admission for diarrhea with severe dehydration. And according to the mother, only after this complaint, he was having the complaint of polyuria. And there was no any other significant admission, especially for any recurrent dehydration with fever. And there was no history of any blood transfusion and no history of any chronic drug intake or any history of any surgery previously being done. And with regards to the family history, he was born out of a 3rd-degree consanguineous marriage. There was no similar complaint in the family. And he had 2 younger sisters and there was no any complaint in both the younger sisters. And with regards to the antenatal history, there was no history of antenatal polyhydramnios. There was no history of polyuria in mother during pregnancy, and there was no gestational diabetes mellitus, pregnancy, hypertension, eclampsia in mother. And with regards to the birth history, it was uneventful. He had a birth weight of 2.5 kilos, and there was no history of any neonatal admission. And he was normal. With regards to development, he studied in class 7, which was appropriate for age. On examination, there was no any craniofacial anomalies, no dental abnormalities. There was no rash or skin nodules or any form of skin lesion. There was no organomegaly. There was no any form of lower limb deformities, no hyperpigmentation. And the BP was checked, which was found to be in the normal range at 100 by 70 millimeter of mercury, and he was pre-pivotal. And
Why
when
are you looking for skin nodules?
The skin nodules, so LCH. And so second possibility can be sarcoidosis.
So skin nodules will be more for sarcoidosis. Skin rash will be there for that. And lytic lesion. You have to mention lytic lesion because if you have early onset, typically what age does LCH present? Yeah, so it is too early for LCH, but you will always consider. So you have to look for any ping pong appearance which is there in the skull. And you will have seborrhea, rash, hepatomegaly, ear discharge, all those will be significant from there. And nodule, again, sarcoidosis, more of theoretical, too early for sarcoidosis to present at 1 year. So this is unlikely to be that. Unless there is some damage which has happened around 1 year of age, as you were saying, some insult which has caused AVP damage, and that could have caused that. But usually when you talk about severe dehydration causing DI, in that perspective, do you think what sort of a course would have been? Can you explain that?
So in case if it had been such illness, he would have had a severe brain damage where he would have been in ICU for a very long duration.
Cannot cause. So mostly he might have been having polyuria, and that's why he became severely dehydrated.
Even for a mild amount of diarrhea, he would have been dehydrated.
And of course, till 1 year of age, he is not drinking that much water. So he would, of course, not be polyuric. So these are more of a corroborative thing from mother, rather than an actual one. So what we are seeing clearly is that we have excluded many of the other conditions in that perspective. Now, what does growth tell us?
So he's having severe failure to thrive and more with nutritional pattern of growth failure because his BMI is more affected and weight is more affected. And this nutritional pattern could be attributed to the fact that he was drinking more amount of water or taking very less amount of calories.
Yeah. So if you have somebody who's taking a lot of water, if you give them free water, they will failing to thrive. Sure. If you give them too much of formula feed, they'll become obese. That are the two manifestations which happens with DI. Carry forward.
And with the summary, he is having significant polyuria and polydipsia since 1 year of age, with a history of failure to thrive, with no recent weight loss, and there was no history of any significant hospital admission, and there was no family history. And the probable diagnosis was diabetes insipidus and primary or psychogenic polydipsia.
Yeah, so as this is more of a theoretical one because 1 year of age presentation is too early for psychogenic. And I'm always questioning this sort of a thing in children. Very unlikely. Adolescence, yes, can happen. I've seen a few of them. But very young age, it is more of a theoretical one which is given in the books rather than the actual practical ones. For me, it is practically DI written all over. So why preference to ice? Dr. Seema is asking. The answer to that is very simple because the receptors in the oropharynx are more responsive to ice. So if you take ice, you will get much contented easier. So that is why they prefer ice, and this is a good history point to look at. There is a question from Dr. Rajib to get the benefits of hydrotherapy if person started drinking a lot of water daily for a month, and is there any long-term effect on brain or kidney functions? Not really. It doesn't really make a huge difference because body is able to take it off in the urine. But if you're drinking a lot of water and you live in a fluorosis prone area, you will develop fluorosis. And very, very long-standing polyuria in DI causes hydrouretronephrosis, non-obstructive hydrouretronephrosis. Mechanism of polydipsia in case of sarcoidosis, that is because of the specific lesions which go up there and interrupt the inhibitory signals to the thirst center. That's the way it goes on that. So we'll come to that polyuria definition, Dr. Sona, now. So when we have a child who comes like this with complaints of polyuria, there are 3 questions you have to answer. Is it polyuria? Is it a problem in terms of solute load or a concentration defect? And then finally, what is the cause? So what really is polyuria? Now, the definition of polyuria depends upon the age. There are different cutoffs used. But generally speaking, if you have significant nocturia, that is very, very significant. If somebody is fine at night, I don't think this is DI. So I'm not going to the exact definition. We'll talk about that. But in general, if somebody is not have to getting up, it is not DI. The major problem is at night. Dehydration, failure to thrive may also be pointing towards significant amount of polyuria, which happened in this case. That dehydration happened at 1 year of age and he is failing to thrive. Fever, more or less in the first year of life. So this is a classical, a young boy presenting to you with failure to thrive, recurrent dehydration, fever, you get a sodium 154, 155, you get a urinary osmolarity very low, 70 to 80 milliosmoles per kg. This is X-linked nephrogenic DI, classical presentation. Seizures, altered sensorium, young child, very early age group. That is the presentation usually. Cold water, which very well highlighted by Dr. Naveen also in this case will be there. And hypernatremia only if you have got diabetes insipidus and no access to free water, like infancy, like post-surgery, and if your thirst center is gone. These will be the three conditions which are there in that regard. So polyuria, you have to confirm by urine output measurement or how much they're drinking. So 2 liter per meter square per day or 5 ml per kg per hour. Now we all know that body surface area and weight do not go hand to hand. So there are different definitions for different ages. But generally, if you say 2 liter per meter square per day, which is quite significant, in this case, it was 5.5 liter per meter square. So it's very high. You won't miss it. The basic workup is just to exclude infection, hyperglycemia, and RTA at the first level. Then these three, I said creatinine, calcium, potassium. So hypercalcemia, hypokalemia, renal dysfunction becomes important, and blood gas, very important. Then you have to, after you've done all that, the next step is whether it is a solute load or a concentration defect. You have to do two things. You have to do a urine and plasma osmolality in the morning. Ask for history of drugs which can cause problems. In this perspective, which drugs can cause polyuria? And
lithium.
And so a lot of drugs which cause tubulopathies, amphotericin B, so many drugs can cause that. You have to worry about that. And look for rickets and acidotic breathing, which is there in that situation. Now this I'll spend some time because a lot of people are confused about how to get osmolality done, how to measure, how to interpret, and that sort of issues are there. So when we say osmolality, it basically means how many osmoles are there in the blood. And this classically is done using the freezing point depression method. So there are machines which will directly measure the osmolality. Now this osmometer is often not easily available in many places. So people use a calculated osmolality, which basically considers sodium, glucose, and BUN. These are the major ones. Now what you need to understand is that glucose is not going to be huge in most cases. BUN is also not going to be huge in most cases. So the single most important determinant of plasma osmolality is sodium. And across the world, the sodium assessment is much more robust as compared to the assessment of osmolality. So if you do not have access to osmometer, if you cannot measure that, forget it, look at sodium. That becomes important. So if your sodium is above 145, 146 and more, minimum it is around 300, because 392 is only because of sodium. Then out of glucose, you will already get about 300. So a serum sodium 146 or more means that you have got a good amount of concentration. At that point, your AVP should be maximum. So if you are not able to get your plasma osmolality, which is reliable, or it is taking time for it to come, look at serum sodium. That will give you a good clue in that regard. The second issue is urinary osmolality. So I've given you a urinary osmolality calculation as well. You can also use the same osmometer to get urinary osmolality, but often it is not available. So what can be done? To look at urinary specific gravity. So there are dipping instruments by which you can measure, or these are refractometer which you can measure. There is also strips, but I find them to be very unreliable. So this refractometer versus the dipping one are the better methods to look at urinary specific gravity. And frankly speaking, there is so much change which happens in specific gravity. So if you don't have osmolality, you can actually use specific gravity as a good measure to look at. So how do we correlate? There seems to be a linear correlation till an extent in terms of the urinary osmolarity and specific gravity. Roughly 280 milliosmoles per kg is somewhere around 1008, which is there in that perspective. 600 milliosmoles per kg is roughly 1015. So if you have 1005, now many of the DI patients, I think we'll discuss about that as well in this case, are 1005. So 1005 is hard, it's like 100 or something, I would say. Once you are 1010, you are more than 300. This is what you can say. And 1015 is 600. So it's very, very easy to identify. So ideally, get a urinary osmolality done. If you cannot, this could be a way. I will give you another simple way of measuring urinary osmolality, that is urinary sodium. Whatever urinary sodium you get, again, easily labs will give you urinary sodium, multiply it by 4. If urinary sodium is 25, osmolality is 100. Urinary sodium is 75, it becomes 300. So if you do not do anything, if you do at serum sodium and urine sodium, you're pretty much done and you will get good results, and they will come very quickly because other results will take a long time. Anybody who has done a water deprivation test will know how difficult it is to carry forward in that perspective. So if it is 1000, that we are not bothered about that. We are bothered mainly about 1008. So I would say 1010 is a good parameter and 1015. These two are important. As for puberty, I say B2 and B4. Here you want to take 1010, 1015. This will give you a good picture in that regards, and there is a linear correlation as I discussed. Now, once you have done everything, you then go ahead with doing a water deprivation test, which is often done in most cases. It should always be done in the hospital. Don't ask the child to get dehydrated at home because then they will develop severe hypernatremia, may have hemorrhage, which may happen. Don't ask for overnight fast. At baseline, check for weight and look for 5% of the dehydration level. Look for urine and plasma osmolality and serum sodium, and then monitor urine output, weight, hydration, hourly urinary and plasma osmolality. Now, how long do we need to do a water deprivation test? It usually will take at least 6 to 8 hours. But if you have like this child who is passing like 5 liters per meter square per day, he will dehydrate within 6 hours. Usually you can say that. But sometimes somebody is having borderline, it may take more time. So depending upon that, the main aim is, this is a very difficult test. You are actually asking somebody whose whole life they have been drinking a lot of water to stop water. It is going to be very, very difficult. So it's a very painful test also. So you don't want to repeat it again. So you want to do it at once and with more clarity. If you need to prolong, you can prolong it. What could be the alternative of water deprivation? What else can you do to increase the sodium?
Sir, I can give a sodium load.
So some people talk about saline infusion test. You can give saline. This is classically done already for hyperaldosteronism. We talked about that. You give saline and see how aldosterone goes down. But here also you can use saline to build up the sodium in that regards. One other test which we'll discuss subsequently is aquaporin level. So aqua is the co-peptide level. What is co-peptide?
Co-peptide is secreted in equal proportions to the AVP.
So co-peptide is like C-peptide. It is like C-peptide of insulin. Co-peptide is a C-peptide for AVP basically. When you produce AVP, you've got AVP, you've got neurophysin 2, and you've got co-peptide. For every mole of AVP produced, you've got co-peptide released. There are some assays which are now available for co-peptide, although they are not very good even in the US. So it's an emerging field, but very interesting. If you look at co-peptide and co-peptide is high, what does it mean? It excludes central DI. So whatever state you do co-peptide, even if your sodium is normal, abnormal, doesn't matter. If your co-peptide is high in a polyuric child, you're dealing mostly with NDI. So a particular cutoff, it's NDI. If your co-peptide is low, you give them saline. After giving saline, the co-peptide should go up. It becomes NDI. If it's not going up, it is central diabetes insipidus. So in coming future, once co-peptide assays are matured, all this will not be required because this is potentially dangerous, difficult, painful. So all these factors are there. But till now, this is the best methodology to diagnose DI in that regard. But co-peptide will emerge later on. Now, very importantly, do not do a water deprivation test if sodium is less than 130. Because this can't be DI. A DI patient cannot be hyponatremic. Or it's more than 145 already. the blood is concentrated. So this is clearly out from that perspective. And if urinary osmolarity is more than 600, it cannot be DI. Already it's excluded in that regards. So the protocol is that you take the weight, you take the target weight, which is 95%, measure sodium, plasma osmolarity, urinary osmolarity, and monitor weight, urine output, urinary osmolarity, serum sodium, plasma osmolarity regularly. You have to tell the lab that we want the results quickly, because if they take 2 hours for the result to come back, you're going to be in a mess, because it's a very dynamic situation. You need immediate. I would say if you can get immediate sodium, urine specific gravity, these will give you a very good picture. Osmolarity will take time in that regards. When would you terminate the test? If the sodium goes above the target, 146 or above, urinary osmolarity is concentrated, or weight goes below target. This is the most soft indications. Often we say, okay, the weight has come down, let's terminate the test. Be careful. If the child is not very dehydrated, carry forward a bit more. Because if your sodium has not gone beyond 146, is he really dehydrated? That's the whole question. If somebody becomes dehydrated, sodium should have gone up. So be a bit more careful in not stopping test when you say, okay, the weight has gone a bit. Like in this case, there was some confusion about the weight, and that caused a bit of a thing. We wanted to terminate it prematurely. That would have caused more confusion in that setting. So what should happen if you stop water? Immediately the urinary osmolarity should go up in a normal situation. And then if it's not increasing, this is DI. In this setting, you give AVP, increases its complete DI, does not increase, it becomes nephrogenic DI. So this is a very, very simple. Anybody who has a concentrated blood should have a concentrated urine. If the urinary osmolarity is less than 300, it is complete DI. If it's 300 to 600, it is partial DI. And then you classify based upon central versus nephrogenic in that. And then you have got the partial, in which it's 300 to 600, no response partial NDI, some response partial CDI. Now this is important. The very AVP plays a role in terms of concentration we discussed, but the medulla also concentrates a lot. If you are having long-standing polyuria, this medullary concentration gradient is lost. And because of this loss of medullary concentration gradient, even if you give AVP, it may not result in a rise of urinary osmolarity. So in somebody like this child who is having polyuria for 13 years, I'm 100% sure that the urinary concentration gradient is lost. So the response to AVP will be difficult. So this will behave like a pseudo NDI or a secondary nephrogenic diabetes insipidus. So that's why the cutoffs have come down. People used to earlier say double the urinary osmolarity. But even if it increases by 50%, that means it's a good enough response. And sometimes the delayed response also may be looked at in that regards. Now, long-standing central DI, primary polydipsia, your urinary concentration gradient goes down, and your AVP is not going to help much in this setting. And therefore, it is the secondary NDI which matters. What you do in this setting is that you actually maybe use a lower cutoff, or you wait for 24 hours. Now, if suppose you have got a mild increase in the urinary osmolarity and you're not sure whether it is nephrogenic versus central, what would be the best approach to go forward, Naveen, in that case?
So in this case, you can actually give a trial of AVP and see if the patient is responding or not. Then you can
So even if you have got slight response, I would say 30%, 40%, it goes more in favor of a central DI rather than a nephrogenic DI. So this whole process may have caused more confusion. It may have masked the response. So in this case, you say, okay, continue AVP, low dose AVP for 2 days, 3 days, and you will see the response immediately in that perspective. However, often giving vasopressin may be just a test. You can immediately know that it is really concentrated. How do you know? So if your color of the urine changes from white to yellow, there is no doubt. You don't need to wait for all that, and you can immediately get the response on that. Once you've given an injection, can the child drink water?
There is a limit to the water we can drink.
So he can drink, but not too much. Like this child, when he was admitted, he drank 750 ml directly, even before getting admitted. So that's what they will have a lot of drinking tendency. So if you allow them, okay, I'll give you AVP and drink 1 liter, 2 liter, he'll develop hyponatremia if it is not DI in that setting. So you have to be careful in that perspective. this is what I was talking about, that water deprivation test has got a lot of challenges which are there in that perspective. So now a new modality by which you can easily differentiate the term is AVP. And for that, co-peptin is just like C-peptide for AVP. So co-peptin is basically a product from pre-pro AVP. We said you have got AVP, you've got neurophysin 2 and co-peptin. It's equimolar amount. It has got a longer half-life, more stable, and you can measure it easily. So co-peptin levels, if you do anytime, any patient with polyuria, if it's more than 21.4 picomoles, it's nephrogenic. If it's low, you cannot say. It can still be both. But then you do a stimulated using a water deprivation, or you give a normal saline and see what happens. If it's still low, it is complete in that perspective. So the approach to polyuria first is, if there is polyuria or not, more than 2 liters per meter square per day, look at blood sugar, potassium, calcium, creatinine, blood gas, urine RM. If all of them is normal, look at urinary osmolarity. If it's more than 600, it's solute load. Other things, less than 600, look at serum sodium. If sodium is more than 145, you do not do a water deprivation test. You give them vasopressin. And if the rise is there in urinary osmolarity after AVP more than 50%, it is central DI, less than 50% is nephrogenic DI. If the serum sodium is less than 145, do a water deprivation test. And if the urinary osmolarity goes above 600, it's compulsive water drinking. If it's less than 600, you have to do a you have to do a AVP response in that regards. So basically, the major test is urinary osmolarity, and then if required, water deprivation test. As things change, co-peptin may become a part of this algorithm, and it will become much easier and simpler from that perspective. So now what happened in this case, Dr. Naveen?
We basically rolled out the screening investigation, which we actually mentioned, mainly in the form of getting creatinine, which was normal, blood sugar was normal, calcium level was normal, and also venous blood gas was normal. And before going to that, we also got a serum sodium level, which was normal, and potassium level was normal. And when we got the urine osmolarity, it was dilute. So we had a dilute serum with a dilute urine. So in this
Non-dilute serum, non-concentrated serum.
Non-concentrated serum with a dilute urine.
And you can see osmolality and specific gravity, again 1005 is around 100. There's no perfect correlation, but this is the rough one.
So in this case, as Saline already mentioned, in a patient with polyuria with low urine osmolarity, we need to get a serum sodium level done. In case if it is less than 145, we had to go in for water deprivation test. As per the protocol, we actually went in for water deprivation test. So on water deprivation test, we got the baseline weight, serum sodium, urine osmolarity, and it was serum sodium was 136, and urine osmolarity was also low.
This is a bit unusual for DI. Having a sodium in the low normal is less likely. But as you were mentioning, he drank 750 ml just before the admission. So that could have caused the sodium to go up. So this is important. While we say that don't do water deprivation right from night, but at least in the morning they should not drink that way, because that will delay unnecessarily because.
So we got the same test repeated at 2 hours and 4 hours. And as you could clearly see, at 4 hours, his serum sodium rose to 146, which is almost equivalent to serum osmolarity of 300 millimoles per osmol per kg. And his
weight increase.
Sir, weight, which was actually mentioned.
All the clothing changed.
Okay, so anyway, he was losing weight.
And
sodium went up.
And but there was no improvement in the. So actually he lost weight. That is what but it was mentioned in the records.
So he of course lost weight. He lost 900 ml of urine, which is pretty good in a 4-hour period. He is losing around somewhere around 12 ml per kg per hour, 13 ml per kg per hour. He's losing around that one. So he'll lose weight definitely. 900 is big. And what you see is that 10 sodium has jumped. That's a big jump. Within 4 hours, getting that jump is huge, which means it's like a definitely DA. Now, urinary osmolarity is increasing, but it has not increased above 300. So it's like a complete DA. Now, here you can make a big diagnosis of complete DA.
So the diagnosis of DI was made, and despite the fact that his serum sodium was 146, he was still passing colorless urine, and there was polyuria. And we got a vasopressin challenge test done. We gave a 0.6 unit of AVP subcutaneously. And at 2 hours, we found that the urine osmolarity increased from 240 to 400, which was almost equivalent to more than 50% rise. And we labeled the patient as central diabetes insipidus.
And there was a change in color.
Color also.
The patient clearly mentioned that the color became yellow. So for me, that is the most gold standard. This is the gold standard test here. What is interesting, at 4 hours, your urinary osmolarity again went down. So there was a huge secondary nephrogenic component which was there. So as we were discussing, that AVP acted for some time, but it did not have a sustained effect. Anyway, the half-life is less. So in that setting, it went down again. So that is why there was some confusion that that's really central DI or it may be a nephrogenic DI. But given this change in color and given it going up to 400, I'm pretty okay that this is the most likely thing. So how did we go forward from there?
So though we actually labeled the patient as central diabetes insipidus, and we also got the MRI done. And MRI report, as mentioned, the bright spot of posterior pituitary was not visualized, and there was no any presence of stark thickening, or there was no features of any intracranial lesion.
So why do we have a bright spot in posterior pituitary?
So basically because of the AVP neurons.
So it's the collection of
new
AVP
people.
in the vesicles. So it's basically the AVP you can see. Now, what are what is the role of this finding? How does it help you?
So it is very in any case of diabetes insipidus, there will be a absence of, or there will be it will become small in size.
In central DI, this spot will go off because you don't have
In
any
AVP,
in nephrogenic.
because all we need to
is. So this is a non-specific finding for diabetes insipidus. It can happen both in central
as well as nephrogenic.
You mentioned very importantly the stalk thickening, because that's an important consideration for malignancies and other risks which are there from that regards.
So we actually started, as there was response for vasopressin in this patient, we started desmopressin 200 microgram tablet minute 0.1 BD, and on initiation there was a drastic change with regards to the urine output, the urine color, and also there was a significant decrease in polyuria. And there was a point that he was not passing urine. It was decreased to almost 1 episode per day. So we further decreased the dose, and we started at a dose of 150 microgram per day, with giving 1 full tablet at night and giving half a tablet morning after the passage of urine. And now the patient is having a significant improvement in symptoms, and he's asked for follow-up after 14 days. And with regards to the cause, it's definitely a case of central diabetes insipidus, because this absence of posterior bright spots can go in for central as well as nephrogenic, as we always discuss. But because of the fact that he was basically responding to AVP vasopressin, this is definitely a case of central diabetes insipidus. So what could be the cause? Is it idiopathic? But to declare something idiopathic, we need to rule out all the causes. And when we actually thought, considering the fact that it was too early to start with, and there was no presence of any malformation, and the nephrogenic DA was ruled out, we went in few case articles where the patient was diagnosed with NPS2 defect, and it was quite similar to the case what we actually are presenting to now. In this case article, they actually mentioned that the lady was diagnosed at the age of 34 years of age, but the complaint started at 1 year. She was not concerned about her because she thought that she had a craving for water, because apart from the fact that she was extremely thirsty and she has to go in for multiple episodes of urine per day, she was not really concerned. But she started to concern, like every mother. The same thing started happening to her child. At the age of around 1.5 years, even he also started pouring liters of urine, and she had to change her pad. And the one thing which she was more concerned was the fact that the child was not growing in weight and also not growing in height. So after that, she was having these symptoms for a period of 30 years, but she was not concerned. But when the same thing happened to the child, and he was not growing in height and weight, so she decided to visit the doctor. And when they got the basic investigation test done, she was diagnosed as a case of DI. And with the presence of a strong family history, they got a genetic test done, and it was found to have a neurophysin 2 defect. And the same testing was also done to the child, and he also was found to have the same defect. And the MRI of the patient, which actually showed a small sized posterior hypopituitary, and this could actually resemble, considering the fact that this child also had early onset and there was no any emergencies for a period of around 12 to 13 years of age, and also fact that there is a posterior bite sort was absent, and there was no any stalk thickening which was actually mentioned, and all the other secondary causes of polyuria have been ruled out. This could more or less could be a genetic cause of neurophysin, and we are actually planning to get a genetic test done on follow-up.
One important thing to remember is that there is nothing called idiopathic central DI. The diagnosis of idiopathic central DI is a harbinger of a serious disorder. Many patients have been found to have craniopharyngiomas years after the diagnosis of central DI. So you have to do a periodic MRI. So even if the MRI is normal, now in this case, if you find a genetic defect, that is fine. Otherwise, we'll have to do a periodic MRI. So doing a genetic analysis will definitely help in that perspective. Now, if we go by this approach, we excluded all the things: blood sugar, sodium, potassium, urinary osmolarity was low, serum sodium was less than 145. So in this setting, we did a water deprivation test and it became less than 600. We gave a rise of osmolarity AVP and we found increase. So this is a central DI. So if you use this algorithm, very easy to approach in terms of polyuria using only urinary osmolarity and a AVP response, which we did in this case. Now, diabetes insipidus could be central. Now, this is important because central, usually you can have malformations which are congenital, but these ones will present with other features. You will have septo-optic dysplasia, you will have midfacial hypoplasia, midfacial anomalies. All the genetic causes of central DI are later. They will present 1.5, 2, 3 years. Like this case, as we discussed, also presented at 3 years of age. It's unlikely that they will present early. Acquired causes can be, this is what we are concerned about, especially gliomas and germinomas. Small germinomas in the stalk can cause DI, which are even not detected on an MRI. So the main thing is to look at stalk thickness. If the stalk is bigger than the basilar artery, you have to start worrying about hypophysitis. You have to start worrying about a germinoma. See how it evolves over time. Now, one parameter which will tell you that this could be hypophysitis is the evolution of anterior pituitary deficiencies and the anterior pituitary size. So if the anterior pituitary size becomes less, it goes more in favor of germinoma than histiocyte, than hypophysitis in that regards. Insults are obviously obvious, and infiltrative disorders like histiocytosis, very important as we discussed, 2 to 5 years of age with rash, seborrhea, ear discharge, hepatosplenomegaly, lytic lesions. Nephrogenic DI, congenital, as I said, young male, recurrent fever, dehydration, mild hypernatremia, 6 to 12 months. Family history, maternal uncle, polyamnios, mother has a history of polyuria in pregnancy. That's nephrogenic DI, X-linked. Acquired, any hypokalemia, hypercalcemia, drugs and obstructive cause. Very importantly, the management has 2 arms. One, as I said, urine output is a product of how much you have got osmoles and how much is your concentration. So you try to decrease your osmoles. So you basically say more free water to the child, reduce solute, and you try to give diluted milk with oil. Now, if you have an infant, you try to increase the calorie density. So you want to have an early weaning, which is happening in that regards. You use a diluted milk, and on that you add oil, which will be of help in that regards. The other thing is to give vasopressin. And of course, vasopressin has got a short half-life, so better would be give an analog like DDAVP, as Naveen was talking about, which can be given as injections, as spray, but we prefer the tablets and the melt form, which are much more better in terms of bioavailability and intake in that regards. Key messages: always start at a low dose because sometimes they will be hypersensitive. Now, this child actually at 100 micrograms developed really long-standing 14 hours did not pass urine. So if you say twice a day, it becomes difficult. If they take it twice a day, even without passing urine, they will develop into fluid overload. So start with a low dose, wait for urine output from happening from the next dose, and then you can build it up gradually. Your major concern is at night. So first take care of the night time, then you start in the morning. Rarely you may have to give 3 tablets, but usually 2 tablets are more than enough in that regards. Monitor weight and sodium. Now, thiazide amiloride is another option. And as I said, if you use diuretic, you got more distal delivery of water and sodium. that will shut off your tubuloglomerular feedback. You will have shrinkage, GFR will be less. If filtered water is less, loss will be less. So this is in a way trying to do, it's not an appropriate way. You're trying to actually shut off your kidneys to prevent polyuria. But that's one option which you can use in severe nephrogenic DI. In some infants, you can use that in that regard. So DDAVP is available as spray. You can use it like a spray has 10 micrograms, which is quite a big dose. So some people use a tube and give smaller amounts from that perspective, and tablet and melt preparations are also available. Start off from around 100 microgram of tablets, go up to 200, usual maximum doses up to 400. In infants, do not giving too much because fluid overload will cause more problems. Better to use fluid and thiazide as an option and monitor weight and sodium in that regards. For nephrogenic DI, as I said, you use thiazide, which will basically cause more load, which is then going to cause more water loss, dehydration, and all the whole process of you will have a problem in terms of the tubular and glomerular function, which will go down. So you'll basically cause a sort of a mild renal failure. So the GFR will come down, but GFR comes down, filtration is less water will come in the urine. The other option is you will also cause hypokalemia because of thiazides. So you have to give amiloride along with that. That will help this hyperkalemia from not happening through the epithelial sodium chloride channel and the indomethacin. Combination of these three will cause 50% reduction in urine output. So treatment of NDI is less effective as compared to central diabetes insipidus, but that's the option which is there in that regards. So you use hydrochlorothiazide, you use amiloride and indomethacin, which is used in that perspective. 30 to 50% reduction, you will cause hypokalemia and gastric side effects which happen. So I think we've tried to discuss a lot with regards to polyuria. The key message is that if a child has polyuria, ask for nocturia, cold water preference, ask for daytime symptoms that will become important. The most important thing to you from pediatrician's perspective is to do a urine sugar. If it's high, it's diabetes. If urine sugar is normal, look at calcium, look at sodium, look at potassium, look at blood gas. If all that is normal, look at urinary osmolarity and plasma osmolarity to decide about the need for further workup in that regard. So you can all go and have a look at our website, join our different grant rounds which are available, our books and mobile applications. So we'll close at that point of time and see if there are any particular questions which are there at this point. Dr. Manisha is asking, during water deprivation, should food intake also be withheld? Yes, because if you take food, it's usually you're going to have some water along with that. What was the cause of decrease in urinary osmolarity after 4 hours? This is what we discussed, that there's the, we use the injectable form, which has got a shorter half-life. And second, there is also a resistance to AVP. So it was able to do some work, but it went off after that. Once we used DDAVP, it had a longer duration of action and the efficacy was there. And already the child was primed to AVP response. So these could be the two theoretical factors which were there.